Hi everyone, thanks for joining me today. And I'd like to speak about how the architecture of our body can influence whether we have and how we recover from chronic pain. There's a lot of variability from human to human, and I'll be showing you what that variability is and a little bit about how that plays out in terms of forming pain. Some of the images I will be showing might be disturbing for some of you because they are showing real human bones. My name's Rick Olderman. I'm a physical therapist. I've been a licensed physical therapist for about, over 25 years now. And I specialize in helping people with chronic pain. Today's talk is about how we're built differently and how this relates to pain. All right, so I get a lot of questions. How do I solve back pain? How do I solve sciatic pain? How do I solve piriformis syndrome? All of these questions. The assumption behind all of these questions is that we're all built the same. And this is often one of the reasons why some people get better and other people don't, is because some people are built differently than others. And so the treatment approach may have worked for someone built in a certain way, but not for someone else. We are not all built the same. And sometimes this has very significant impacts on how we should be treated. All right, to understand almost all difficult lower body, pelvic, or back pain, practitioners must know how to test for and solve problems based on the architecture of a patient's or client's body. This is especially true if someone is not responding to your treatment. There may be an architectural issue going on, and I'll show you what those are. A lack of a deeper understanding of your specific architecture is often why people develop chronic pain. If you're struggling with chronic lower body, back, or neck pain, this is likely one of the reasons. It's because your practitioner or you don't understand the uniqueness of you. Here's an image of 6 different thigh bones, and you can see that from this end to this end, they change. All right, you can notice that the head of the thigh bone is pointing more up at this end than at this end. And you can see this is the knee part, and this is the part that goes into the hip socket. So that all of the knee parts are resting on the same parts of the knee. So those are all oriented the same. The difference is either in the twist of the thigh bone or the shape of the neck. Here's that first one, and then here's the last one. Look at the variability. This has significant consequences for what should be done to solve pain, and we'll go over some of that in just a second here. But I also want to talk to you about, look at the difference in the length of the neck here versus, say, maybe the length of the neck here. I mean, that's like a millimeter or centimeter longer than this one. This has huge implications for the muscle function and activity that we would engage in, right? Whether we're successful or not. If you found this information useful and helpful, please subscribe and like this video, but most importantly, please share it with other people with back, sciatic, or SI joint pain, because this is a big deal for a lot of people, and it could help a lot of people. That's why I'm making the video. And then if we look at this thigh bone, if we look at this head here, you can see how much of that knee portion is showing here, but in this portion, look, very little. So the angle of the bone as it relates to where the knee is also changed, not just the neck angle, but the shaft angle as well. Now, it's not necessary that you know this significant, minute detail with every single patient, but sometimes a general understanding that there is a difference in how people are built and how to work with those differences makes the difference between someone getting better and someone who isn't getting better. Here's an image of an ilium. What I first want to point out, the thing that might jump out to you is, wow, here's the sacrum, here's the front of the pelvis, and look at the curvature of that sacrum and the space between this and this, and then look at this sacrum as much straighter and much closer to the pelvis. And if we look at this area here, this is where muscles are attaching that attach into the thigh bone. Look at that shape versus this shape. All right, you can see there's much more potential muscle mass that muscles can attach to over here than here. So this has implications for instance, posterior fibers, posterior meaning the back, being present or even more active or stronger in someone with this type of orientation than this person who may not have that degree of posterior fiber network. Now, the really obvious thing is, here is the hip socket. Look at how that is pointing towards us, and this one is pointing forward. This one is pointing almost straight out from the hip, and this one looks like it's angled slightly down from the hip. Let's say that you go to yoga, and everyone believes that they should move just like their yoga instructor. But that yoga instructor is built in such a way that allows the movement that they are achieving to occur. What if they have a hip socket that's shaped like this, and yours is shaped like this? Well, then of course the leg can't go back as far as this person. And of course this will have larger range of motion laterally from the body than this person. They're being blocked here. And if you try to force that motion to occur because you quote unquote believe that that's the correct way of doing it, then you're only going to be impinging bone and labral tissue in the hip socket and damaging that. I say this for you all to give yourselves a break. We're all built differently. And just, it's not so much important that you know exactly how you're built, but just knowing that you're built differently gives you an allowance to maybe not be just like that person that you're comparing yourself to. Here's another one. Look at the shape of the ilium here, splayed out more, and these are more straight up and down. Now, I would venture to guess that this is a male pelvis and this is a female pelvis because of this is the birth canal here. And it needs to be wider in a female than a male to allow for the baby to pass through. And then, believe it or not, this ilium will pivots out in the first part of labor to allow the baby to drop down. And then in order for the baby to pass through, this then can pivot in and open up the bottom here to allow the baby to pass through. I think a lot of men would be complaining if our pelvis did that. So that's one of the more obvious differences that we see here. But again, here we go. Here is the orientation of the acetabulum, or where that thigh bone is meeting the ilium or the hip joint. The orientation here versus here, completely different. So I will expect a completely different type of movement from someone than here. Now, do I know the orientation of someone's hip socket? No. However, I do understand the amount of rotation here. We can test that. And so that gives me great feedback as to what we should be doing with that patient. So now we're moving on to the sacrum. So the sacrum is this backbone here in the pelvis. This is the front of the pelvis. This is the back of the pelvis. Look at the differences between these sacral bones. And so this area here is where that articulates with the two ilium, those two big broad flat bones attach here and here. This forms the SI joint. And sometimes these SI joints are oriented differently. And the width of the sacrum is different. The length of the sacrum is different. The curve of the sacrum is different. So to assume that everyone should be operating just the same all the time is just not really accurate. You have to understand the individual architecture of the person you're dealing with, mostly when they're not responding to your treatment. Those of you who are stuck with chronic pain, who have not been helped, maybe this is what is going on, is that your practitioner doesn't understand how to measure for things like this. I think this is our last image. Look at the curvature of that sacrum versus this one. Big difference. Flat, curved. You fall on this sacrum, it's going to mean something different than if you fall on this sacrum. So here we are again back into these bones, because now we're going to talk about the consequences of this type of rotation. Now, this is what's called an anteverted femur. So if we were to turn this head of this bone so it faces into the hip socket here, you would then notice that the knee would have to rotate inward too. So that's an internally rotated thigh bone or an anteverted thigh bone. This is often referred to as femoral torsion. However, you can have femoral torsion this direction and the opposite direction too. So I don't believe torsion is specific enough. Torsion, in my mind, just means stress. Well, that doesn't really identify why the femur is under stress. Femoral anteversion identifies that the specific type of rotation that femur has. And so it's easily tested in the clinic. But aside from being able to test it, you have to understand the implications of this. And this is what is not taught in most medical programs. So let's look at this. So here's an illustration of femoral anteversion. So now I've turned that hip so it's facing correctly into the hip socket rather than facing up this direction. And lo and behold, the thigh bone is now twisted so that the knee is rotated in. That's more what this thigh bone would look like if we were to look at it from head on, or if it was sitting in a hip socket, this thigh bone would look like this one. So what happens as a consequence of that is that the thigh bone, because it's rotating in more, it tends to collapse in more towards the inside. Well, that can then be a driver to create more excessive foot pronation on this foot than the other. Yes, you can have femoral anteversion more on one side than the other. In fact, I've seen people with one femoral anteverted femur and one femoral retroverted, which is the exact opposite. So it can happen in all sorts of different ways in people. So if you have femoral anteverted femurs, typically the knees tend to knock together. I would expect to see more foot pronation issues. And then what also happens as a consequence of the knees either coming together symmetrically or asymmetrically is then you get the pelvis becomes off because of one thigh bone rotating in more than the other. That creates a whole nother host of types of problems that I categorize as side bending problems. Again, we're talking about femoral anteversion, which is excessive internal rotation of the thigh bone or the knee joint, or that the hip bone is pivoting the opposite direction. If we take this, well, what does that look like muscularly? Well, then this plays out as a series of compensatory tight or weak muscles throughout the body that then creates this phenomenon, which is what I was mentioning as the side bending problem, all right, where one side of the pelvis appears higher and usually the same side rib cage is lower. This is called scoliosis. If a doctor were to take an x-ray of you, they would say, oh, you've got scoliosis. Well, scoliosis only means lateral curve. There are two types of scoliosis. Well, there's probably more, but I break them down into two. There's functional scoliosis, which is a compensatory scoliosis that occurs because of problems like this. This functional scoliosis creates one curve. Congenital scoliosis creates two. So there'll be an S curve like this with congenital scoliosis. Congenital means born with, and that has different consequences. How your body is built can drive the degree of that scoliosis, and that degree of that congenital scoliosis can change if you fix the other issues that's contributing to the scoliotic pattern. I don't want to leave you in the weeds here, but I just want you to understand basically that the shape of the thigh bone can create a scoliotic curve in the body and all of these compensation patterns. Here's what it looks like in real people, all right? If you take your shirt off and have someone take a picture of your back, you'll see that maybe there's a bigger crease on one side than the other. And if you look really closely, you might notice that one hip is higher than the other. This is exactly what I'm describing here. Now, in medicine, in neutral spinal mechanics, if the spine is in neutral and we side bend to one side, the spine must rotate to the opposite direction. And you can almost see that here. Look how fleshy that is on this side of her spine and not fleshy on this side, because her spine is side bent to this direction, but also rotating to the opposite direction. Most of the treatment books that I've read all deal with fixing rotated vertebrae. That always returns because you're not fixing the driver of the rotation, which is the side bending problem. The side bending occurring is the driver behind the spinal rotation. Well, what's causing the side bending problem? Well, one of the causes is possibly a femoral rotation. These can be measured. Here it is in another person. Here it is in some more. You can see how common it is. Big crease, little crease. Look how high that pelvis is on this side. And this side. And this side. Notice that it's almost always higher on the side of the big crease. We're talking about femoral anteversion here, but this can also occur with femoral retroversion. Most practitioners will call this a leg length discrepancy. Oh, well, you must have a longer leg on this side. Absolutely not. Look at all of the potential compensations that are occurring up this chain in order for the side bending to occur. What most practitioners will do is they'll stick a heel lift under the lower side, usually, to bring them level. But that's not solving anything, or if it does, it's only a superficial solution. It's not solving what's causing this whole big crease in the first place. That's what you want to solve, and it's so easy to solve and fast. But this is not a leg length discrepancy, folks. The opposite, I've mentioned this a couple times, is femoral retroversion. So again, the hip bone is sitting in the socket correctly, but now the thigh bone is twisted to the outside. Here's what it looks like head on. All right, it's the opposite of femoral anteversion. This typically occurs in men, and femoral anteversion will typically occur in females, if it's going to occur at all, leading to very similar compensation patterns based on how you're using your body in the presence of these issues. Again, very easy to measure whether you have it, and frankly, to understand what to do if you do have it. I help patients every day who have this, and they master it, very quickly. So what else can cause these types of patterns? Well, asymmetrical thigh tightness. Well, why might a thigh be tighter on one side than the other? Because you're using your leg incorrectly, which causes the thigh muscles to become tighter. You may have more of an anteverted or retroverted femur, or you may have symmetrical anteversion and retroversion. However, you're using the legs differently. Let's say you're a soccer player, so you're posting on this leg more than this one. Well, then this one might be developing more tightness issues than this one that's kicking the ball and needs to be freer. Things like that all add up to create these types of patterns. Another thing is anterior femoral glide syndrome. This is a problem where the thigh bone in the socket is careening around inside that socket like a washing machine that's out of balance. Why is that happening? Because the gluteals aren't turning on. Why aren't the gluteals turning on? Because that is a problem with how you're walking and using your legs based on femoral anteversion or retroversion. There's just so many permutations to this. But regardless of all of the permutations, it's very easy to solve if you just have a basic understanding of this system's thinking, which is what I'm describing here. The good news is that knowledge of this, even though you're following just 80% of what I'm talking about here, or even 20% of what I'm talking about. The takeaway should be, gosh, if I have chronic pain, maybe it's because my practitioner doesn't understand how to measure the architecture of my body. And maybe that's what I'm missing, is an understanding of that. I want to bring hope to people that you can solve these things. It's not your fault that you're still in pain. You're doing everything that you're told to do. The problem is, in medicine, we're not trained to look at things like this, test them, and fix problems based on this type of phenomenon. You are not broken. You just haven't had the right information yet. You haven't been looked at from a systems point of view, which is kind of how I describe understanding the ramifications of these kinds of things. You have to understand the body as a system. And so I describe this as a systems point of view, as opposed to, say, how we're trained in PT or medicine or chiropractic is component thinking, where we see a problem and we try to fix that little problem. You got back pain? I'm going to look at those vertebrae. But we're not looking at the lever arms of the body that are acting on those vertebrae. Those, because they're lever arms, they have a much more significant impact. Those vertebrae aren't becoming rotated or side bent or scoliotic just on their own. Something is driving those issues. And it's usually things like this. I would strongly encourage you to join my free masterclass for back and sciatic pain, where I'll take you through tests to help you understand why you're having pain, and then give you a plan on what needs to happen to solve your pain. And I've also created some digital home programs to help people solve their pain at home. That can be found on my website at www.rickolderman.com. And I have some other free information there too. So I hope to see you there as well.